Hello, my name's Gordon Doig, and I'd like to talk to you today about early enteral nutrition in critically ill patients. But before I begin, I would like to thank the conference organizers for inviting me to present to you today, and I would also like to thank Nutricia for making this session possible. The final recorded version of this talk and a PDF copy of the slides will be available on our outreach educational site after this conference session. And at the end of this talk, I will show this QR code again, and it will take you straight to our website. So in this talk, I would like to provide you some background on what early enteral nutrition is. I'd like to provide some clinical evidence of benefit in different critically ill patient populations, and then conclude with some specific clinical recommendations. So the concept of early enteral nutrition was first popularized in the mid-1980s by trauma surgeons, and some of these trauma surgeons were very proactive early feeders. In fact, the clinical trials on this topic routinely started enteral nutrition as soon as shock was stabilized, so this would be before going to the operating room. And if it couldn't be started then, they were fed on their way out of the operating room with surgically placed feeding tubes. Since 2005, major ICU guidelines have been recommending early enteral nutrition, and today, just about every single guideline on this topic makes a recommendation for early EN. Early EN saves lives and reduces costs, but unfortunately, the majority of ICU patients around the world still start enteral nutrition too late, except, of course, in Australia and New Zealand. So today I'm going to present some evidence from systematic reviews on this topic. And there are many different hierarchies of research evidence. This is one proposed by the Oxford Center for Evidence-Based Medicine. And it suggests that the foundation of all our knowledge is expert opinion. But this needs confirmation with objective evidence. And the objective evidence often starts with case series or case reports, case control studies, or other observational type studies. Now, this is highly relevant today in the middle of our COVID-19 pandemic, because most of you have probably seen all sorts of observational studies that show very promising benefit from many different treatments. But unfortunately, a lot of these treatments have not been confirmed by randomized control trials. And what I mean is that the observational studies look beneficial, but the randomized control trials, when they're conducted, they don't show the same magnitude of benefit. And that's because randomized control trials remove all sources of treatment bias and give us our most objective estimate of treatment benefit. But in the middle of this COVID-19 pandemic, you've probably also seen a number of different clinical trials coming to print on the same topic. And this is why many different systems place systematic reviews and meta-analyses at the top of the hierarchy of evidence. Because the purpose of a systematic review is to identify all RCTs on a topic, objectively evaluate, and then present the objective evidence to you, so that you can make your own treatment decisions. Interestingly, many major ICU guidelines are based on systematic reviews of the evidence. And we're going to start by looking at one of the most popular guidelines around, and this is the 2016 version of the Society of Critical Care Medicine and the American Society of Parenteral and Enteral Nutrition guideline. And we're going to focus on the systematic review that they conducted to look at early enteral nutrition. And here are the clinical trials that they found on this topic after an extensive literature search. But before we go into the results, I wanted to highlight this one clinical trial to you. And for now, I just want you to remember the name, Beer Holgerson. So just remember that this clinical trial is included in the SCCM guideline, and we're going to talk about this a little bit more later in this presentation. So now, back to these clinical trials. SCCM identified 21 clinical trials that were on topic, And they conducted a meta-analysis of these 21 clinical trials, and they concluded that enteral nutrition, early enteral nutrition, significantly reduces mortality. So they make a clinical recommendation for starting EN within 24 to 48 hours of ICU admission. Now, the first thing that I wanted to know when this recommendation came out was, how hard do I need to work to start enteral nutrition on the first day of ICU admission? Because the first day of ICU admission is always very busy with many other different things to do. So if I can wait to 48 hours, that would be really great. So let's look at the clinical trials in here. And we notice that over half of them actually started enteral nutrition within 24 hours of ICU admission, while the other half will allow you to wait a little bit longer, sometimes up to 72 hours. And what we're really going to do here is divide these clinical trials into two groups. And we're going to reconduct the analysis of this first group, the clinical trials that start enteral nutrition within 24 hours. And when we do this, we find that there is a significant mortality reduction. When we look at the clinical trials that allow us to wait a little bit longer, we find that there is unfortunately no effect on mortality. So the most recent SCCM clinical recommendation is based on a systematic review of 21 clinical trials. But when we look deeper at this systematic review, we learn that the clinical trials that started EM within 24 hours demonstrate a significant reduction in mortality. But if we wait after 24 hours, there's no mortality benefit. After finding this result, what I wanted to know was, are there any other systematic reviews that also demonstrate a benefit from early EN in other critically ill patient groups? So here's the first systematic review on this topic, published in 2018 in Critical Care Medicine. It focuses on general ICU patients, and it did an extensive literature search to find clinical trials that started enteral nutrition within 24 hours. It identified 6 clinical trials on this topic with approximately 250 patients. And when meta-analysis was conducted, it demonstrated that early EN significantly reduces mortality by about 9.2%. It also reported that early enteral nutrition was associated with a significant reduction in pneumonia. Now, this is important because many people are concerned about starting EN early because they don't want to have regurgitation, aspiration, and pneumonia. But clearly, none of these clinical trials suggest that this might happen. Next, we find a meta-analysis published in 2011 that looks at major trauma patients. These trauma patients were defined as having an ISS greater than 20 or an abdominal trauma index greater than 15, and all of the patients in these trials required ICU admission for care. After an extensive literature search, only 3 trials were identified in this field that report mortality in their patients. With approximately 120 patients, meta-analysis demonstrated a significant reduction in mortality by 8.2%. Our third systematic review on this topic was conducted on burn patients with major burn injury defined as greater than 20% total burn surface area. Not all of these patients would have been cared for in an ICU, only the ones that also had an inhalational injury. So many of these patients would be cared for in a non-ventilating burn unit. But there is significant overlap, and these patients are highly relevant to us. But the most important notable aspect of this study is we conducted this in collaboration with our colleague in Chengdu, Dr. Pu, and she searched the Chinese National Knowledge Infrastructure Database to identify clinical trials conducted in China involving Chinese patients. So here we have 7 clinical trials with over 500 patients, including 2 clinical trials from China, suggesting that early enteral nutrition started within 24 hours of burn injury significantly reduces mortality by 7.4%. This meta-analysis is very informative. It also shows that patients who received early N had less GI hemorrhages, reduced sepsis, and reduced pneumonia. And here's our fourth clinical trial. This clinical trial focused on patients who had major lower GI tract surgery. And some of these patients were randomized to receive early EN if they were cared for in an ICU, but most of these patients received an early oral diet containing protein. Again, we worked on this meta-analysis with colleagues from China, this time Chengdu and Chongqing. And we searched the Chinese National Knowledge Infrastructure Database to identify, appraise, and include clinical trials conducted in China. Now here we have over 650 different patients, including randomized controlled trials from China. Before I get into the results, I want to highlight this clinical trial at the top right here. This is the clinical trial by Bjerre Holgersen, conducted in 1996 and included in the SCCM guideline on nutrition in the ICU. I wanted to point this out to you because this meta-analysis is highly relevant to patients that we see. Many of these major lower GI tract surgery patients require care in the ICU for the first day or two. And indeed, if you notice this name too, CAR was also included in the SCCM ICU guideline. So when we look at these patients and we meta-analyze these results, we find that an early protein diet significantly reduced mortality of patients with a lower GI tract surgery. But also, early EN resulted in less intra-abdominal peritonitis and abscesses, a reduction in surgical site infections, a reduction in serious post-operative complications, and a reduction in all post-operative infections. So we have evidence from multiple systematic reviews demonstrating mortality benefits from enteral nutrition started within 24 hours of the onset of critical illness. We have the reanalysis of the SCCM guideline demonstrating a reduction of 7.7%. We have a meta-analysis published in 2018 that demonstrates a significant reduction in general ICU patients. We have a meta-analysis from 2011 demonstrating a reduction in mortality by 8.2%. An analysis of major burn injury patients demonstrating a reduction of 7.4%, and a systematic review and meta-analysis of major lower GI tract surgery patients that also significantly reduce mortality. But what if we change the question at the top that we're asking? What else can we learn from these systematic reviews? What if we're concerned about critically ill patients with shock? Well, I could create an argument suggesting that all of these patient groups are likely to be in shock. But let's look at or focus on the patients with major trauma. So trauma guidelines have been making recommendations for early enteral nutrition since 2004. And this is the wording from this early trauma guideline. And it clearly says enteral feeding can be instituted in most patients after resuscitation is complete and hemodynamic stability has been gained. If we look at these clinical trials, they tell us when they considered hemodynamic stability had been achieved, and they defined this as a shock index less than or equal to 1 for 1 hour. So if they had achieved stability for 1 hour, you were enrolled into the clinical trial and early enteral nutrition could begin. So stable shock is not defined by weaning or removing vasoactive agents. It's defined by achieving your treatment goal for shock. And this is a major clinical trial from Australia where we enrolled approximately 1,500 patients, and we defined hemodynamic stability by systolic blood pressure greater than 100 millimeters of mercury without the need for increasing doses of vasoactive agents for 1 hour. Back to all of our systematic reviews. And this time, what if we're interested in patients with compromised gut blood flow? Again, I could argue that many patients in shock and all of our ICU patients might have compromised gut blood flow. So maybe I'm concerned about everyone. And all of these systematic reviews show benefit in patient groups with compromised gut blood flow. But let's look at the major burn injury systematic review. Let's bring it up to the forefront. It's very important to note that these patients are accepted to have extremely compromised gut blood flow. But when enteral nutrition was started within 24 hours of injury in these patients, they reported a significant reduction in GI hemorrhage, accompanied by a significant reduction in sepsis and pneumonia, suggesting the gut barrier function is preserved and we're not compromising the gut anymore by feeding early. We're actually protecting the gut. We've got strong evidence in the systematic review of gut protection. And indeed, if we go to our laboratory research, we know from our best or most widely accepted model of burn injury, that is the burn guinea pig, that independent of cardiac output, early EN results in a significant increase in blood flow to the small and large intestine after a major burn. So maybe enteral nutrition is not stressing the gut. Maybe actually enteral nutrition is relieving the gut from its stressor by increasing gut blood flow. So in summary, we have multiple systematic reviews conducted in different critically ill patient populations that demonstrate early enteral nutrition reduces mortality when early is defined as less than 24 hours from ICU admission. We know from clinical trials that early enteral nutrition can safely be started as soon as resuscitation is complete and shock is stabilized. I've given you two relevant and working definitions of stable shock from two different types of clinical trials. And shock is not, or stable shock is not defined by weaning or removing vasoactive agents. We know that early enteral nutrition demonstrates a strong protective effect in patients assumed to have severely compromised gut blood flow from our meta-analyses of patients with major burn injury and also from our animal models. And early EN has been proven to have multiple benefits in patients who've had major lower GI tract surgery. This is highly relevant to many patients who come into the ICU with a surgeon who's cautious about feeding. This systematic review demonstrates that feeding patients with who've had anastomosis and major gut surgery actually benefits and helps them heal faster and avoids major complications. So I would close with this very simple recommendation. Start your enteral nutrition as early as you can, very slowly and very gently, and aim to reach your targets by 72 hours after ICU admission. Thank you very much for your time. It's been a pleasure.